We're going to break Chapter 56 up into a couple different lectures. So this is beginning the care of patients with non-inflammatory intestinal disorders. We'll start with IBS. So irritable bowel syndrome is the most common digestive disorder in the U.S., and 1 in 5 people in the U.S. have it. It's a functional GI disorder that causes chronic or recurrent diarrhea or constipation, or both, and might include abdominal pain or bloating. So essentially, irritable bowel syndrome has increased or decreased bowel transit times, and it results in abnormal bowel elimination. There are different classifications of IBS. So we have IBS-D, which is IBS with diarrhea, IBS-C, constipation, IBS-A, alternating, or IBS-M, which is a mix. Symptoms usually start occurring in young adulthood and continue throughout someone's life. The etiology of IBS is unclear, but it can be a combination of environmental, immunologic, genetic, hormonal, stress. Those could all be factors. People with IBS they're considering that they might have a bacterial overgrowth. But also, women are twice as likely to get IBS than men, so that's where the potential hormonal interaction comes in. One of our big interactions with patients with IBS should be about teaching dietary-wise, just health teaching. So we need to help them increase their dietary fiber. 30 to 40 grams of dietary fiber every day. That's going to help produce bulky, soft stools and create a normal bowel pattern. Also encourage them to drink 8 to 10 cups of fluid every day. Drug therapy could be, well, it depends on what symptoms they have. Do they have diarrhea or do they have constipation? So it depends on their symptoms. Stress reduction. So this is kind of like it's going to help with motility, especially if they have constipation. But also there is a little bit of evidence that probiotic supplementation might help. Some evidence shows peppermint capsules might help, so that complementary and alternate medicine has a little bit of action in irritable bowel. We have to really think about, as far as our role in IBS, not only just education, we also have to think that about educating patients of how common this is, because we have a lot of psychosocial concerns with these folks. We might see them to become nearly homebound because of, especially like those folks who have IBS-D with diarrhea, they might have a fear of not having a bathroom near them when they have an episode, so might end up staying at home, totally change their lifestyle. Secondary depression is also not uncommon in these patients because this is a lifelong disease and there isn't a cure. Let's discuss some abdominal hernias that we might see. This graphic is a description of abdominal hernias. Hernias are weaknesses in the abdominal muscle wall, and through that weakness, we can see a segment of bowel or other abdominal structure protrude. Hernias develop usually because of muscle weakness and increased abdominal pressure. So the most significant factors that increase abdominal pressure are going to be obesity, pregnancy, and lifting heavy objects. So these would be our 3 biggest risk factors for developing hernias. Your Iggy 8th edition, page 1146, is where this graphic can be found, and it's going to be an appropriate, this graphic is going to show some appropriate assessment locations and would be a potential question on like an exam. Hernias can be defined as reducible or non-reducible. So reducible hernias is when the contents of the hernial sac can be pushed back into the abdominal cavity. Usually this can be just done with gentle pressure. It's not something that us as nurses would do. If a surgeon wants to do that or a GI physician wants to do that, that's fine. Oftentimes, though, you will hear that patients do that on their own. This is something that we wouldn't want to do because it could potentially perforate the bowel. So that's reducible as one type of hernia. Irreducible or incarcerated hernia is when it can't be pushed back. This is potentially dangerous because, and it requires immediate surgical evaluation because it could lead to a strangulated hernia. A strangulated hernia is when the blood supply to the herniated segment of the bowel is cut off because of that hernial ring or the band of muscle around the hernia. So this could potentially cause ischemia and obstruction, but if someone waits too long, it could lead to necrosis and bowel perforation. Signs and symptoms for strangulated hernia are going to be abdominal distension, nausea, vomiting, pain, fever, and tachycardia. Now, oftentimes we see hernias managed with surgery where they'll go in and reduce the hernia and potentially even have to put in some mesh to hold the hernia in. But there are also non-surgical management. Some folks who are not surgical candidates might have a truss, which is essentially a big padded belt that's going to help keep the hernia from strangulating.